Good morning to all of our esteemed faculty and delegate. I am Somnath on behalf of INTAS. I welcome all of you to this online learning platform webinar. I'm sure this unique platform will help all of us to enrich our knowledge to keep the ball rolling for the MHG webinar. Let me just share the screen. Okay, is my screen visible? I would like to. Is my screen visible, sir?
Yes, visible.
Okay, so I would like to invite our program director, Sri Professor Dr. M.B. Agarwal, sir. So, he's a professor and head Department of Hematology at Bombay Hospital Institute of Medical Science, Mumbai. She is also a consultant hematologist at Lilavati Hospital, Bridge Candy Hospital, Mumbai Hematology Group, as well as the past president of ISHBT, an institution in himself, an inspiring inspiration to many and teachers for all of us. So India is fortunate to have him as an enriched person. I would also like to invite our moderator, Sri Dr. Amit Khurana, sir. So he's done his fellowship in bone marrow transplant, MBBS and MD, and in hematology, fellowship in clinical hematology, and sir is practicing as hemato-oncologist at Surat. Dr. Amit sir is a highly skilled and experienced oncologist with a decade of experience in this field. Sir has a fellowship in bone marrow transplant, hematological clinical hematology, and is an expert in many hematological programs and as an hemato-oncologist patients. Sir's rich experience in performing bone marrow transplant is an aspiration to many of us, as well as a bone marrow biopsy. So I would, in order to keep the ball rolling for systemic mastocytosis, I would request Dr. Amit sir to keep the to take this to share the slides. Thank you, sir. Thank you very much for coming, sir.
Thank you, Mr. Somnath Banerjee, for the kind words. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Surgeon Commander Dr. Arun V.A. from Mumbai, and he's going to lecture us on systemic mastocytosis. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Anil Handu from Delhi, our guest speaker for the day, Surgeon Commander Dr. Arun V.A. from Mumbai, all our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for spending the Sunday morning, afternoon, and evening. Let me give a flavor of next weekend activities. Next Saturday, that is 23rd of December 2023 from 6:30 p.m. Indian Standard Time onwards, we have two webinars, two lectures on the same day. The first one will be Dr. Suprakash Sanyal speaking to us on ruxolitinib-based treatment of primary myelofibrosis from Fortis Hospital, Mumbai. And the second one is Dr. Nazima Gangat from Mayo Clinic, Rochester, Minnesota, USA, speaking to us on JAK2 unmutated erythrocytosis diagnostic and therapeutic approach. And following day, that is Sunday, 24th of December 2023, from 11:30 a.m. IST onwards, we have again Dr. Suprakash Sanyal speaking to us on polatuzumab-based treatment for newly diagnosed DLBCL, and Colonel Dr. Rajan Kapoor from Army Hospital RNR, Delhi, speaking to us on relapsed DLBCL, challenges and novel treatment. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Aditi Shah from KM Hospital, Parel, Mumbai, Dr. Aditya Jandial from Homi Baba Cancer Hospital and Research Center, Mulampur, New Chandigarh, Punjab, Dr. Akshay Manloy from Agilus Diagnostics, Mumbai Reference Lab, Mumbai, Dr. Ankit Rayani from Cure Hematology Oncology Clinic, Ahmedabad, Dr. Aryan Jain from PGI, Chandigarh, Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, HIMS, Dehradun, Dr. Gopinathan M from MGM Healthcare, Chennai, Dr. Neen Mia Thanda from North Okalappa General Hospital, Myanmar, Dr. Jyoti Bajaj Soni from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Kunal Chatani from Nagpur, Dr. Kunal Goyal from ACTRAC, Mumbai, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Pujita Bai Reddy from CARE Hospitals, Banjara Hills, Hyderabad, Professor Dr. Colonel Prakash Chetalkar from Sri Aurobindo Institute of Medical Sciences, Indore, Dr. Ramesh Balasubramanian from Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu, Dr. Satish Kumar A from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow, Colonel Dr. Uday Yanamandra from Armed Force Medical College, Pune, Dr. Yimon Tan from Yangon, Myanmar. Now it's the time to introduce our very special guest for the day. We have with us our chief guest, Dr. Anil Handu from Delhi. He is a very, very famous personality and very, very renowned hematopathologist who does not require an introduction. But it's my formal duty to introduce Dr. Anil Handu. Dr. Anil Handu is MD in Pathology, Fellowship in Hematological Medicine from London, Fellowship in Flow Cytometry from Australia, Principal Director and HOD, Laboratory Services at BLK Max Super Specialty Hospital, Delhi. He has over 20 years of experience in the field of laboratory services, particularly hematology and flow cytometry. He is an expert on various national and international committees for hematology and flow cytometry. He is a faculty for flow cytometry for industry and academic institutions. He is a technical assessor for NABL in the fields of hematology, molecular hematology, and flow cytometry. He has received various awards and distinctions during his medical education. He is a life member of Indian Association of Pathologists and Microbiologists, Indian Society of Hematology and Transfusion Medicine, Delhi Society of Hematology, the Cytometry Society, and International Clinical Cytometry Society. It's my privilege to welcome Dr. Anil Handu to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Anil Handu.
Thank you very much, Dr. Amit. It's indeed a proud privilege for me to be actually on this forum today for two accounts. If you look at, I am on a forum which I have always kind of revered because when I started my career in hematology, Dr. M.B. Agarwal, the epitome of hematology in our country, used to be the driving force for me to think, in terms of hematology. And it's again a privilege to be introduced by someone who followed me in my college, subsequent to my PG there, and eventually went into hematology and it's really doing well. So it's a proud privilege for me on both the accounts. I have somebody who I looked up as a guru and somebody who followed me up, eventually introducing me for the webinar today. So without further ado, I'll just give you a brief thought about how hematology has evolved over the last 2 decades that I have been in. It's when I joined pathology as an MD resident, the blast percentage for acute leukemia used to be 30%. And so we would look for 30% blast. And of course, there used to be confusion even those days with respect to how many percent should we look for an LBL and stuff. But nevertheless, 30% was still a cutoff at that moment. By the time I finished my MD, it had dropped down to 20%. And now, today, irrespective of whatever the percentage is, it's all about molecular. So, when I look at in last 20 years, what has changed in hematology, it's a sea change from where we started to where we are today. And I think it's still a very dynamic branch. What makes hematology very unique is it's a beautiful amalgamation of three streams, actually. The three streams include the laboratory hematology, clinical hematology, and the cellular therapies. Today, we are at a stage where CAR T cell therapy happens to be the big game changer. And I think a lot of responsibility lies not only on the clinical colleagues to ensure that the CAR T cell therapy is available, which is all anyways happening, but also to our laboratory professionals, to the hematopathologists, the ones who are already there and the ones who are in making, to ensure that we are able to eventually look at those, therapies and then see whether those therapies have worked or not. And that's where the biggest role comes in because it's not easy detecting a measurable residual disease when you're doing a CAR T cell therapy by the conventional methodologies. So I think not only are our clinical colleagues evolving in the area of hematology, on the clinical front, both on the conventional clinical diagnostics, looking at things from a deeper perspective, and then eventually coming back to therapies, whether it's immunotherapies or cellular therapies. But it's also pushing and leading the other branches, affiliated branches, to ensure that they're able to give them more than 100% to ensure that they are, kind of supporting them in all the possibilities. So I think a very nice bonhomie between the clinical and the laboratory fields happens to be the cornerstone for hematology practice worldwide, not only in our country. In fact, in majority of the centers in places like UK and places like Australia, the hematology is not even considered as a laboratory science. It's actually considered a clinical science where, both the parties work together and ensure that the diagnostics are given appropriate standpoint, and at the same time, therapeutics are also, given appropriately by the same. So I think we are at an anvil, and I think there has been significant, what I say, progress with respect to the number of people getting into hematology. If I look at when I started my career, DM hematopathology had just started, and to a day to day where we have almost about 15 to 20 centers across the country offering hematology education. Whether we talk about fellowships, whether we talk about MDs, or DMs, or we talk about DRNPs. Fortunately for me also, we have students who are coming into our institution as DRNBs, and I'm glad that, one of the discussants is from our institution, who's there in the list, which I just saw, which Amit actually showed us. And without further ado, and really getting into the time which the speaker needs to be speaking to us about systemic mastocytosis, I think I would just end by saying that great times and greater times ahead. That's what we are looking forward to as far as hematology is concerned. And I'm really honored and privileged to be a part of the program today. And I will take it forward now to Dr. Amit to take it to the speaker for the rest of the session.
Thank you so much, Dr. Anil Handu. You are always my guru and remain a guru forever. Thank you so much, sir, for joining us today. Let me share the screen again. Now it's time to introduce our guest speaker for the day. We have with us Surgeon Commander Dr. Arun V.A. from Mumbai. Dr. Arun V.A., Surgeon Commander, is Associate Professor of Medicine and Clinical Hematologist at INHS Aswini, Kolaba, Mumbai. His qualifications include he has done his MBBS, MD General Medicine, and DM in Clinical Hematology, and very special achievements. He has represented Indian U16 cricket team from 2001 to 2002 and Kerala Ranji Trophy team in the year 2003. He has over 44 publications. His awards and felicitations are as follows: President's Gold Medal, Best MBBS Cadet, AFMC 2007, MUHS Topper, First, Second, and Third MBBS, First in Grading Exam, MD Medicine, and Associate Fellow, NAMS 2022. He has got the Best Research Paper in Hematocon 2018, SITSCon 2017, and IBM FS 22. He is a winner for the National Hematology Quiz, Clinical Infectious Disease Society Quiz, and Epicon 2016. And today he's going to lecture us on systemic mastocytosis. Well, thank you so much. Over to you, Dr. Arun V.A.
Is my screen visible? And
Yes.
am I audible?
Yes, perfect.
At the outset, I will extend my warm regards to the Mumbai Hematology Group and Dr. Agarwal in particular, who has been a genuine inspiration for me when I began as an intern in Kolaba uh, many years ago, and to where I stand now as a novice in hematology, still inspired by the amount of energy he enthuses in each of the interactions we have had over the years. So without much ado, let me just continue with my topic. Today, I'll be discussing systemic mastocytosis, an entity which actually has flummoxed you, I would say, physicians, clinicians, immunologists, hematologists, hematopathologists. You can name it because there is a definite delay from the suspicion of this condition to the diagnostics and then to the therapy, because everyone is perplexed, I would say, the patient, the clinician, and even the pathologist sometimes by this entity. So I will be covering the topic under the following heads: a brief introduction, and then I would go through the topic under the following heads before I conclude. So to begin with, we must know what mast cells actually are. We must know these are connective tissue resident myeloid cells. So they're myeloid in origin, and they form a part of our innate immune system. So they will have a say in inflammation wherever it's going on in the body. And definitely they have a role to play in tumor defenses and angiogenesis. We must know before we go any further that The central regulator for expansion, differentiation, and maturation of mast cell will be the stem cell factor. And before we even interpret and start discussing the diagnostics, we must be very clear what the morphology of a mast cell is like. So if you see this picture, the top left, the picture labeled A is what a normal mast cell would look like. A small to medium round cell with a single nucleus, lot of granules with metachromatic properties. And if you see the picture on the B is actually what is taken from the skin tissue. And you can see these are typically perivascular in location in any connective tissue. But the moment you come down to the bottom two figures, this is how the shapes become bizarre when there is a neoplastic mast cell. You will see they are spindle or spindeloid, I would say. That's how the morphology changes, the granularity reduces, there can be nuclear dysmorphism and all. So that's how the morphology would vary. And if you see a normal bone marrow essentially would constitute around 0 to 0.2% mast cells. It's important to understand how the biology would be when you have a normal mast cell developing to that of a neoplastic mast cell. It's important to know that the figure on the left tells you how a normal mast cell develops, and it's all driven through what is called as the stem cell factor, which I just alluded to. And you will see that the mast cells will mature from the progenitor cells to committed cells, and as they mature, they become functionally active. So it's a carefully orchestrated stem cell factor driven process. But on the right, you would find what happens when there is a neoplasia coming in. Here also, although the KIT mutation, which we keep harping on, has a part to play, but it's singularly not just responsible for mast cell proliferation. What would be important here are driver mutations, which we don't know actually, and some of it we do know, and they do come in early in the development of these mast cells. Some of these driver mutations start right away at the stem cell levels. That's when you will have an aggressive malignancy. And most of it is primarily when the mast cell is developing, that's when you have indolent mastocytosis coming in. Before we go any further and to my topic in particular, this is the whole gamut of mast cell disorders. This could be represented in this beautiful three circles. If you see the bigger circle that represents mast cell activation, the reason may be anything from a simple venom bite or to an anaphylactic response where the mast cell could get activated. But within that activation circle, which is big, you have this mast cell activation syndrome. Now, MCAS is mast cell activation syndrome. That is when the patient comes to our attention because that's when an organ is compromised, be it cardiovascular, GI, or neurology. That's when they come to our attention. But even then, that doesn't qualify for mast cell proliferation because you will see that the clonal mast cell proliferation, which would qualify for a systemic mastocytosis, is a very small intersecting area. It's a very small niche wherein the patients may develop mast cell activation syndrome. So essentially, systemic mastocytosis, when you use the term, it means there is presence of neoplastic or clonal mast cell infiltrates in extracutaneous tissues. And you would see that although the disease was in existence as early as 1869, I would say, when the first description was somehow alluded to, it had to be documented on an autopsy case, finally in 1949, to be labeled as systemic mastocytosis in a pediatric case rather. We don't have accurate epidemiological data, neither does the West have, although there is a registry in Europe and in US, and they do know that the numbers are around 30,000 a year. But we don't have any accurate figures in India. But we do know it's a rare disease. 5 to 10 per new million would be what you would encounter in a year. But as more knowledge is being disseminated upon, the entity is now coming into existence even in our country. It's very important because I will be primarily talking about systemic mastocytosis. The pediatrics are actually the group of people who would actually get to see a lot of mastocytosis, but that's what happens in the first year of life in a pediatric population. And they do come with the typical skin lesions, the urticaria, and the further similar symptomatology, which we'll come across. But what is important to know that systemic involvement in this pediatric group is fairly uncommon, less than 10% of cases. Although the KIT mutation, which we do talk about, do exist in about half of these patients, although they are not deactivating mutations sometimes. But in an adult, essentially, when you talk about mastocytosis, the onset is around third to fourth decade or beyond. It's a systemic disease. And you don't label it a systemic disease primarily because you're not investigated it properly, or you stop investigation at some point of time. Important to understand the variable course of the disease, and most of it is indolent systemic mastocytosis. You would see 80% of it is indolent. It's indolent because people can live normal lifespan. But as you go into an advanced systemic mastocytosis or a mantle or a mast cell leukemia, you would see that the lifespan really comes down to less than a year. And most of these adult onset systemic mastocytosis are KIT mutation driven. So how does the classification of WHO evolve? That also enabled us to guide how the understanding about this entity has shaped. So we had a subcategory of mastocytosis under the bulk of myeloproliferative neoplasms way back in 2008. It was reclassified as a distinct category into 2017 when we had a revised classification. And we must know today we have the WHO 2022 and the ICC, which I'll be discussing. But suffice to say that you should not exclude or include the possibility of systemic mastocytosis without going for a tissue diagnosis. And the cornerstone of tissue diagnosis will be a bone marrow study. So to sum it up, if you see the WHO 2022 diagnostic criteria, we must know there is one major criteria and there are four minor criteria listed here. The one on the left is a major criteria, which emphasizes on bone marrow biopsies and extracutaneous tissues showing multifocal dense infiltrates of mast cells. Now, to demonstrate multifocality and the dense infiltration of these numbers, it is next to impossible sometimes for a morphologist alone to make it out. So that's when you would use IHC or mast cell markers like a tryptase or a CD117 to delineate and define them. Also important are these minor criteria, which touches upon the morphology of mast cells. And I did tell you how the typical round mast cell becomes spindle shape, or how does the granularity change when it becomes a neoplastic configuration. In addition to morphology, we utilize the KIT activating mutations. We see the IHCs on the mast cells and see the expression of three CD markers, CD2, 25, or 30. It is and or, it need not be together. And definitely serum tryptase, which has a very important role when you are on the path of mast cell diagnosis. Before I move on to the KIT activating mutations, I would spend a moment on the tryptase part. In our country, not many labs do the serum tryptase level. If the lab sends it outside, the report comes in 2 to 3 weeks time. SRL does it, OnQuest does it. Few of the labs do it. The cost is around 15 to 20,000. The turnaround time is sometimes 2 weeks. So these are the problems we have on ground when we define this entity in our country. Important to know what KIT is. So KIT is CD117. It is the receptor for the stem cell factor. And if you see onto the right, it will have various domains. ECD would be the extracellular domain, and then there is the tyrosine kinase binding domain and the extramembrane domains. Suffice to understand that this is a type 3 tyrosine kinase receptor for the stem cell factor, which is a growth factor for mast cells. 21 exons, and you would see that 95% of the mutations which drive systemic mastocytosis are in the tyrosine kinase domain, and the hallowed D816V mutation, which we see in about 80% of cases of SM, are in the exon 17. And you could use any tissue. You could use the bone marrow, the peripheral blood, or an extracutaneous organ to demonstrate the mutation. And previously, a lot of NGS was being done, and because sensitivity of NGS doesn't match an allele-specific PCR or droplet PCR, an allele-specific PCR or a digital droplet PCR is recommended now and not an NGS anymore. Definitely, we will discuss what a B finding is in systemic mastocytosis after you have diagnosed it. There is a submission from the WHO that the burden of the mutation, which is the VAF more than 10%, would qualify as a B finding. So this is what a B finding in systemic mastocytosis is. It tells you about the burden of the disease. because that's important to define and classify systemic mastocytosis. So a B finding will be defined in terms of the burden which you find in the marrow and in the other visceral organs. So in the marrow, you look at simply the mast cell burden. So you could see what is the infiltration grade in the marrow if it is more than 30%. You can also surrogately make a mention of or make a measure of the mast cell burden by the tryptases levels and like what I alluded to, the burden of the KIT mutation in the marrow or the peripheral blood to talk about the mast cell burden. You would look for signs of MPN and MDS, and definitely organomegaly is important to define here. So it's partly clinical in the form that there is palpable hepatomegaly or splenomegaly without ascites or without hypersplenism, because when there is target organ damage, it would qualify as a C finding as well and not as a B finding anymore. And you see the definitions of lymph nodes here. Either they are palpable or you could see them on imaging. So any of this would be qualifying it as a B finding. And now comes the C finding. These are terminologies which are unique to systemic mastocytosis. So each one of us should know this. So the C finding defines what is target organ damage in systemic mastocytosis. And when you have target organ damage, you're looking at marrow failure, you're looking at the organs which fail, that is the liver, the spleen, the GI tract, the bone, which bear the brunt of muscle activation. So cytopenias clearly defined by the ANCs, the hemoglobin, and thrombocytopenia. For hepatopathy, you clinically rely on ascites or hepatomegaly, but investigation-wise, you look at the alkaline phosphatases, and definitely an imaging and a Doppler and a high-sag ascites enable you to demonstrate portal hypertension. In splenomegaly, yes, it's a clinical finding, but with hypersplenism, again, you need a marrow and cytopenias to prove it. GI tract, again, you look at malabsorption and definitely hypoalbuminemia and weight losses. Bone, again, something like you would see the sclerosis is a very common finding. Osteoporosis is a very common finding. But what defines a C finding here are large size osteolysis or with pathological fracture. And like myeloma kidney, now the terminologies are very clear. To define a C finding, this has to be corroborated by a histopathological correlation. Just the numbers or the patient meeting the numbers won't mean. You need tissues to diagnose organ involvement or the C finding in mastocytosis. A subtle difference in how WHO and the ICC takes it, but this is more to to leave us with some confusion and less of clarity. You can stick to either of these and still manage the patient. Now, important is when you apply the criteria, which is the B and the C finding, having diagnosed systemic mastocytosis, how would you classify systemic mastocytosis? So somebody who has less than two B findings, that is somebody who has less burden disease, this is what the large chunk of mastocytosis is going to be. That's where you would label them as indolent. Somebody having two or more B findings would be smoldering systemic mastocytosis, provided they don't have any C finding. Moment C findings come in, and just like what I discussed, the target organ damage, it becomes aggressive systemic mastocytosis or ASM. Always look out for a concomitant myeloid lineage disease in the marrow, and if it exists, it could be an MDS or a CMML or an AML, and that is when you have an aggressive systemic mastocytosis and an associated hematological neoplasm. All of these have treatment ramifications, which we'll allude to. So if you see the entity of an aggressive systemic mastocytosis with an associated hematological neoplasm, you will see that the prevalence is not too less. So if you have somebody where you have labeled somebody as advanced systemic mastocytosis, two of these three may have an associated AHN clone which is evolving. And this clone may evolve. I'll show you a diagram where you can see how the clone evolves. And the other way around, if you have labeled somebody as MPN or an MDS, be on the lookout for underlying systemic mastocytosis as well, because one third of these are missed. And how do you do that? You have these red flags. You have an AML or an MDS or a CMML patient with persistent monocytosis, eosinophilia, splenomegaly that is unexplainable or it is persistent, high burden in the off-kit burden in the peripheral blood or additional. This is where you would actually suspect that these two are coexisting. This diagram beautifully sums it up how a normal stem cell could evolve clonally and have multiple subclones, and you could have something starting with a chip. This is what we see when we have mutations on the TET or the SRSF2 and all, and you see that as development proceeds, they may acquire some of these mutations which are myeloid in origin. We know about the ASXL1, which again is a kind of a myeloid clone, and some of these may acquire the SM-driven mutation, which is a KIT mutation, and then they can just sub-branch and have an additional RAS mutation. So what I would want to say is this is how the disease could evolve at any stage and present to you. It could have a concomitant disease or with one disease phenotype overpowering the other. So you'll have the SM phenotype overpowering the AHN and the patient primarily coming to you with the mast cell activation syndrome. Sometimes you'll have the AML or the CMML, which is the predominant lesion. A new subcategory which we must know is the bone marrow mastocytosis subgroup, which was formerly included in the indolent systemic mastocytosis group. But we should know that this patient would fit in the ISM or the indolent systemic mastocytosis criteria, but has a very low basal serum tryptase level, and there are no mast cell infiltrates in extramedullary tissue. Primarily important for diagnostics and prognostication because the progression tend to be a lot slower. So with all this background, how does a patient clinically come to you? The standard teaching is the triad of skin findings, the symptoms of mast cell mediator release, and those due to organ infiltration. These are like I would say, a spotter for most of us clinicians. You'll see the characteristic urticaria pigmentosa, which can come on the trunk or the limbs. This is the mastocytoma on the left and the telangiectasia on the right. The classical Darier's sign, which is described in mastocytosis. But these are predominantly cutaneous symptoms. But what actually the patient comes along is with a multi-system presentation. So you can have systemic symptoms like a B symptom, but if you see, you can have cutaneous, cardiovascular, GI, musculoskeletal, neurological, and respiratory involvement. Usually, the patient comes with a combination of these. The systemic neurological symptoms are very, very broad and non-specific. What primarily drives the attention or makes us suspect mastocytosis maybe these anaphylactic episodes, the postural syncope, or the syncope which brings the patient to medical attention. Some of relentless diarrheal episode, malabsorption syndromes, where the patient gets referred from one specialist to another, and somebody who comes with bone pains which are unexplainable and has osteoporosis. These are the subsets which would warrant systemic mastocytosis suspicion and further evaluation. So if you see the spectrum, you would see that as the disease becomes more aggressive to the right, you would have target organ involvement or what is called a C finding as a defining feature of the illness. And as the disease is primarily indolent, that is a large chunk of mastocytosis, you would have cutaneous, GI, or cardiovascular symptoms, which defines the illness. To further allude to the point, I'll briefly discuss in a minute or two the case we managed in PGI during my DM program and which we published in the British Medical Journal. This actually would enable you to understand the nuances of diagnostics, the evolution of both the presentation and the management aspects as well. So this is about a 61-year-old male who comes to us with B symptoms, that is fever and weight loss. You will see that this patient is fairly symptomatic for a year with a significant weight loss of 22 kilos and ascites. We took a detailed negative history and he's a diabetic and hypertensive. You see the examination findings here, gross anasarca with significant generalized lymphadenopathy, pallor, palpable liver, splenomegaly, ascites. This actually would throw up a lot of differentials, which could be a lymphoreticular, myeloreticular, malignancy, to storage disorders, to infiltrative disorders. So this is what the patient's hematology was. You had normocytic, normochromic anemia, thrombocytopenia, hypoalbuminemia, raised alkaline phosphatases, and reduced IgM with the raised ferritin. We did the ascitic fluid analysis. It shows us a high SAG, low protein ascites. The hepatosplenomegaly is confirmed on imaging, and we do get nodes all over the body above and below diaphragm. We initially go ahead and actually rather it is the emergency team which takes over and gets an FNAC done, doesn't yield much, some granulomatous inflammation. And the initial cervical lymph node biopsy, because there were spindle cells and initially interpreted as the ALCL, even by the lymphoma histopathology team in PGI. That's how the biopsies can flummox or confuse anyone. But in the subsequent slides to show, I would see how typical the bone marrow findings and the subsequent lymph node biopsy was. And we did do a lymph node biopsy block, NGS, and that's when we get the characteristic KIT mutations. Because he had GI symptoms and portal hypertension, we had done an endoscopy that did show us nodular lesions and the biopsy was consistent. So this is how the axillary lymph node biopsy is. You can see there's a complete effacement of the nodular architecture by pale nodules. And you see these nodules are actually interspersed with spindle to epithelioid cells, which are very tricky. And you may commit for a lymphoma diagnosis. But if you see the IHC, you can clearly see the diffuse CD45 positivity and tryptase positivity and the other negative immunohistochemistry markers. And this is the IHC for the CD117, it's positive. You can see the beautiful degenerating rather mast cells in the bone marrow aspirate. Diffuse sclerosis, which you can see in the marrow biopsies. The nodular aggregates of scattered mast cells in the biopsies again. You can see them. This is the reticulin stain. And you can see these mast cells, how angry looking they are, and they're quite atypical for a normal looking mast cell. You do the IHCs to see the burden of mast cells in the biopsies with tryptases and a 117. You do the duodenal nodules, which are suspicious looking. Even they did show mast cell infiltration and positivity for CD117. And because we had a load of CT at our disposal because of myeloma patients, we keep staining. We can see that we didn't find any lytic lesion, but what we did find are sclerosis, which you can see in across the axial and the appendicular skeleton, which is a common finding with aggressive systemic mastocytosis, although this wouldn't contribute as a C finding. So we had a final diagnosis of an aggressive systemic mastocytosis with a liver dysfunction and financial problems. Midostaurin was not a possibility in this patient. This is how most of us would manage in India with the resource constraints we have. We would use rather interferon with an overlap of steroids and then taper it off. We did follow up the patient, and when I left PGI, it was around 2 years or 6 months of follow up. The patient had a significant clinical improvement, and the patient is still under follow-up at PGI. And what was this was written up also in the BMC. That's what I alluded to with some take-home messages that how could ascites come in and be later evolving. The diagnosis could be aggressive systemic mastocytosis. So with all that, when do you suspect? So when you have a mast cell activation syndrome, that is when anybody could suspect systemic mastocytosis. And that suspicion should be confirmed on a marrow biopsy, which I'll discuss. But invariably, this is the lower chunk is what most of us deal with. We have a multi-system disease, which has cytopenias, GI involvement in the form of malabsorption, liver disease, unexplained, no alcohol, no NASH, no BCD, no infiltration. That's when we must suspect organomegaly, unexplained B symptoms, bone pain, or unexplained osteoporosis. There is a beautiful score of REMA. This is what is utilized for somebody who come with a mast cell activation syndrome. And you could just look at the gender, the symptoms, and if you have tryptase level, before you leave the patient from the emergency or discharge the patient from emergency, after the life-saving intervention of epinephrine, do the score, and if the score is 2 or above, please do evaluate him at least on an OPD basis for an underlying clonal mast cell disorder. So if you have to approach a suspect, this is a beautiful review of literature on the topic and review by Arok et al., who sums it up fairly. Somebody who has a mast cell activation syndrome, you could utilize the scoring, which I just said, and could utilize it for defining or working up for systemic mastocytosis. But somebody who has a multi-system illness, which I spoke to you about, the baseline testing would definitely have to be involving the serum tryptase and what I told you, use a high specific PCR on the blood, which could be an allele specific or a droplet PCR for the KIT mutation. And if both of them are positive, the diagnosis is essential. But if either of them is positive, the patient needs further evaluation. And the further evaluation will be in the form of a marrow. And from there, you could further evaluate for the C findings and define whether the patient has aggressive systemic mastocytosis or indolent, and then refine. Before I conclude, I will discuss the management aspects because that's what clinicians are bound to do. So before we manage any case, like what we do in hematology is risk stratify patients, because I told you a large chunk is indolent systemic mastocytosis. They may not need any treatment as such other than addressing symptoms of mast cell degranulation, which is essentially antihistaminics, mast cell stabilizers plus minus steroids. But a small chunk would need cytoreductive therapy. That is where we have the advanced systemic mastocytosis group, and that's wherein the targeted therapy has come in with tyrosine kinase inhibitors. We still utilize our debulking agents, immunotherapy with interferon and the stem cell transplant in a rare subset of our patients. So how has prognostic systems evolved in systemic mastocytosis? So whether you go for the IPSM, which is the International Prognostic Score, or the Global Prognostic Score, the IPSM is what we use for indolent systemic mastocytosis. The GPSM could be used for both the indolent and the advanced form. And you can see the variables vary from the age, the alkaline phosphatases, the beta-2 microglobulin, the counts, the skin lesions, and definitely now that the NGS has come in, you are looking at 2-3 mutations, especially the SAR. SAR would stand for the SRSF2, ASXL1, and the RUNS1. You can refine your prognostication, and that's how you have seen that these prognostic models have evolved primarily from a clinical risk model to a clinical molecular risk model, where you incorporate adverse mutations as well. So suffice to say, whatever you use, these are applicable, but you can beautifully stratify these colored lines, separate out, and you will see as you come down, lower down, the average survival would be less than a year when you prognosticate a patient. So when we discuss mast cell systemic mastocytosis management, the cornerstone and the life-saving measure, or the thing which actually improves the quality of life upfront, is how effectively you manage the mast cell activation syndrome. Very vital to have this epinephrine pen auto injectors. I think it's a good thing we discuss in our forums. I have myself haven't found a single epinephrine pen in Chandigarh, and even in, I think, most of the centers are actually not having these epinephrine pen, or none of our patients have access to them for auto injection. And that has to do a lot to do with the education we give and the kind of praise we have for fancier things. So what actually would save a patient's life is this auto injector pen. And in one of my subsequent slides, I would rather say how vital is this to save patient's life, because at the first suspicion of anaphylaxis, which we must educate the patient with, the patient is supposed to lie supine to reduce the risk of hypertension and take a shot of epinephrine. That's all what is going to save the life of a patient. In addition, symptomatic treatment, you could use antihistaminics, mast cell stabilizers, and LGCR for the bone pain. And somebody who gets the DEXA scan, which is an essential part of investigation in every patient. With osteoporosis, bisphosphonates are the standard of care, and even patients who do not respond to bisphosphonates, you could use interferon or cladribine. And in somebody who's not responding to antihistaminics and mast cell stabilizers, we have omalizumab and anti-IgEs therapy as well. So when it comes to the debulking agents or the cytoreductive agents, you could see the column number 2. What is listed here is the interferon, cladribine, imatinib, dasatinib, then the midostaurin and the transplant. At least in our country, all of these are available to us. So suffice to say, with interferon, you will find that these are all single center, short studies, or rather small subgroup phase 2 studies. The response rate with interferon is to the tune of 50%, and here you are talking about overall response rates. This is indefinite therapy till the time the patient has benefit or till there is toxicity, either financial or interferon-related toxicity. The patients do respond, but mostly these responses are very short-lived. Cladribine is a very good agent for most of us. Again, we have our experiences with cladribine with hairy cell leukemia. Again, you will see the responses are fairly good depending upon whether the patient has an advanced systemic mastocytosis or has an accompanying myeloid neoplasm as well. Imatinib, a point here, or with dasatinib. Imatinib and dasatinib, the approved use is only for those 20%, I would say, who don't have a KIT D816V mutation. Although there are specific mutations where imatinib works well, in somebody whose mutation status is not known, you could use imatinib. Again, the responses are tune of 20-30%, not much of complete response rates. Midostaurin was a game changer, I would say. If the drug was utilized as early as 2011, it came into the approval somewhere in 2017. It is now available, at least in the AML setting. We have been using midostaurin, and this does help. And for some of the patients who have a matched sibling donor who is fit enough for a transplant, if they can be pushed into kind of a CR, you could do a MAC transplant and have a meaningful overall survival benefit as well. Last few slides on individual agents. So I would say cladribine is what we have in hand. So we must know what we know about cladribine and systemic mastocytosis in 2023. This is the longest follow-up from the European registry you see, which talks about the responses and resistance to cladribine in patients with advanced systemic mastocytosis. An encouraging kind of response, I would say. The data from 79 patients. The follow-up is fairly long, but I would say you see that the response rates are fairly good. The median overall survival is around 2 years. But what is important to know that if somebody has mast cell leukemia, which is a fairly aggressive malignancy in itself, this is not the way to go about it. And somebody who has received less than 3 cycles of cladribine doesn't reap the benefits out of it. With cladribine, the way you give cladribine is 0.14 mg per kg per day for 5 days or 4 days. The cycles are repeated. The most of the data is around 9 to 10 cycles repeated, depending on the patient's tolerance, 1 to 3 monthly. So the toxicity accrues, and sometimes sustaining cladribine cycles are difficult. And when you use cladribine, that's what we use. What we must know is the ISPM and the MARS are not predictive. So don't utilize these prognostic systems if the patient is being utilized on cladribine. Midostaurin approved in 2017 by these landmark trials, I would say, phase 2 data. We did show an overall response to the tune of 70% with some major responses. The overall survival of 2 year and a half, that's fairly good. This is what best I think somebody who's affording can afford now as on date in India, because the subsequent tyrosine kinase inhibitors are not available anymore in India. What is important to know, if you are really having patients of mastocytosis and midostaurin, a more than 25% reduction in the burden would actually predict the survival far lot better. Now, what we have is with midostaurin and cladribine in hand is some data to suggest which is better. This is basically a propensity score weighted analysis, because there are not going to be head-to-head comparisons, being a rare disease, and there is a lot of registry-based analysis here done. So what it does tell us, when you have midostaurin, it was superior to cladribine only with respect to leukemia-free survival and maybe an overall survival as well. So this does tell us somewhere midostaurin will overpower cladribine when it comes to managing systemic mastocytosis, especially the aggressive forms. Avapritinib is a new molecule. Being a scientific forum, it is my duty to tell you that we have a drug which is approved now as early as 2021, based on the phase 1 Explorer study in advanced systemic mastocytosis and a phase 2 study as well. The beauty of the drug is it's a highly selective D816 inhibitor, so the side effects are a lot less. More important is that 1/3 of the patients go into something called a CMR, which is a rarely achievable thing with any of these drugs. The importance of CMR is two things. Somebody who cannot tolerate or cannot afford, the TFR comes in, or the treatment-free remissions come in. And the other thing is, if you have a patient in CMR, this is where you should transplant the patient and be off the drug forever. And you see, the data is not too mature. We have 2 years survival data, 2/3 of the patients surviving. So I would say this is a game changer. And maybe 5 years from now, we'll have this drug in our hands. So these are some of the results of the Explorer and the Pathfinder studies in advanced systemic mastocytosis. The duration of responses, I would say they're sustaining for almost 3 years. That's something good to see. The time to response is fairly less. That tells us that the drug is essentially very effective. And now avapritinib has moved into the indolent systemic mastocytosis IM as well. because there are patients with indolent systemic mastocytosis who have been given two lines of supportive care in the form of antihistaminics and immunotherapy. They're not doing well, and there is a lot of symptom burden, and that's wherein evaporatinib would still have a role to play. Now, if we there is some push from the pharma that we know, and evaporatinib definitely needs to be compared with the best available therapy. And you will see the best available therapy at that time when this study was done, that is 2022, included cytoreductive therapy and biologics, including brentuximab vedotin because of CD30 expression in some of the mast cells. So before we read too much into this, we must understand there will be a lot of biases because the trial settings are different. There is a lot of multi-registry data here, but definitely it tells us that there is a survival benefit with this tyrosine kinase inhibitor. That's the way to go about it. With an FDA black box warning, I would say with evaporatinib that the risk of ICs is fairly high in somebody when you start with evaporatinib, especially when the platelet counts are less than 50,000. So in somebody whose platelet counts are less than 50,000, this will not be the drug, or you will have to build it up to that level and monitor the patients more aggressively. Having discussed the best in the best of the drug in the field, so what is in store for us? This is the RK Lakshman's middleman in the middle, and this is where most of us tend to treat our patients. So the way forward to Bharat, now that we have had our mission in the moon, is I think we must be aware as physicians, and we must be suspecting a mast cell disease, especially the clonal disease, promptly in some of our patients who come to our emergencies, who gets referred from the GE clinic, from the allergy clinic, from the chest clinic, from the neurology clinic, from the endocrine clinic, with this multi-system involvement. We need a lot of pathology and logistic support if we have to make any idea about this disease. We have to have serum tryptases at the drop of our hat for both diagnostics and maybe for monitoring. We should have easily accessible Doppler digital PCR and allele specific PCRs for the KIT mutation. The refinement in the art of looking for mast cells. We have a pathology colleagues who do help us a lot in seeing the marrow biopsies and aspirate in great detail and not missing out on that mast cell infiltrate which hidden somewhere in the paratrabecular foci. And unless we are together in this, that's when disease registries would have a role to play. If we all pool in, because when we wrote up that case report, there was not a single published evidence-based review, rather a case report from India, clinical case scenario where everything, including the mutation, was being done. So that's the large chunk of data which is missing from our country. Sure, we have mastocytosis, but we need to collaborate to have registries on the disease. Generic TKIs would be the way forward for us from maybe 5 years from now. Till that time, we have cladribine, maybe midostaurin, interferon, and imatinib. At least in our setting, we must be able to choose the transplant option widely. But what we have seen and what is available in the literature as far as the transplant consensus among best in the field is that unless we push the patient into some sort of CR or CMR, the transplant is not going to give you meaningful outcomes. My last slide for you. This is a beautiful touchstone survey which was just concluded in US of A, which has an collaboration network for all mastocytosis patients with around 30,000 patients registered. This is the data from the US where we see the best of the care is supposed to be given, right? Rather, and the from the West. So you see that there is a delay even there. The delay in diagnosis is almost close to 5 year plus. You will see that there is a large symptom burden in all patients, although some of these treatments, including the TK, are covered under insurance. And you will see that what was heartening to see is that the number of patients who are keeping the injectable EpiPen, which I alluded to, a large number, 90% had the auto injectors in their hand and were comfortable using the epinephrine. That's something which is very, very heartening to see. And that's where we have to pitch in, and our patient education would play a role. And before I conclude, these are the take home messages I think about this topic, which I will tell the audience here, that we have systemic mastocytosis, a rare myeloid kit driven clonal disease, debilitating symptoms and target organ disease across the multiple organ systems is what defines this illness. The diagnosis and the management are challenging, although we have refined the art of classifying it better, diagnosing it better, and maybe treatment offerings in the form of generic TKIs in the making. And I would rather say, with all the data that's available, the KIT blocking selective TKIs is the way to go forward in systemic mastocytosis. once we have access to these drugs. Thank you all for the patient hearing. This is where I practice now, and this is Ashwini for all of you, a beautiful hospital tertiary center by the seaside in Colaba. And this is where we learn a lot from our patients, and we help the patients out as well as help the August gathering here with the kind of experience we have managing these patients. Thank you everyone for a patient hearing.
Thank you, Dr. Arun, for that fantastic update on mastocytosis. It was a great learning. And I now request all our discussants to please put the raise hand signs so that we can start our question answer session with Dr. Arun. Yes, Dr. Ramesh Balasubramanian, please go ahead.
So good morning, sir. It was a very nice talk. So I want to discuss one case of us, a girl, 10 years old girl, was diagnosed as AML, and she was A21 positive, and her marrow was showing numerous mast cells. And the NGS revealed KIT mutation, and she was also having other high-risk mutations like ASXL1. Like initially, we gave 7+3 induction. She went into remission, except for the fact that she had persistence of the mast cells. Otherwise, she was not symptomatic. Like she didn't have any skin lesions, and she was okay otherwise. MRD was also negative, but this mast cells was persistent. We went ahead with consolidation. We gave 3 cycles of high dose Arasi, and she is in remission. But she is still, since she has got high risk mutations, we are planning to take her up for a transplant. But when we repeated the marrow this time also, like after the completion of consolidation, the mast cells are persistent. Like, does it have any prognostic significance, and should we give any further cycles, or should we give add on something to eradicate the mast cells before taking up the patient for transplant? So MRD is negative.
Thank you, Ramesh, for that question. So, the concept of small brain mastocytosis with that associated hematologic neoplasm is evolving. So, for the patient you spoke about, there is a beautiful consensus statement in 2021 which talks about AML and associated systemic mastocytosis. So, if it is a c-KIT mutation, which is 816V, which is very specific for systemic mastocytosis, or an activating mutation for that matter, and we had it, we knew we had this patient awareness of this right from the beginning. Midostaurin should have been part of the therapy in the initial induction one, and definitely regarding the prognostication, moment there is a mast cell clone, this patient becomes a high risk candidate. This is the consolidation strategy. Best consolidation strategy for this patient should have been a transplant. Now, when you move into a transplant with the mast cell burden, which is untreated, definitely the mastocytosis clone is going to be overpowering the outcome, right? So you have to push the patient into some kind of CR. I'm not saying CMR because we don't have avapritinib, which will push the patient into a CMR. But with midostaurin, yes, you could push some of these patients into a CR. Because if you take up the patient for a transplant with the mast cell clone in unattended to, this clone will evolve and definitely the patient would fail this transplant. So the way to go forward for this patient, I would say, with midostaurin now, and if you could utilize it in the one of the post consolidation strategies and induction strategies, it would have been a bit better. That's what I would say for this patient. The prognostication changes. AML prognostication changes. Although ELN doesn't mention this, but these are all subgroup analysis and these are consensus statements. So the evidence base for saying this is based on expert opinion and a few retrospective and prospective data, right? So, but I would rather do this for this patient with the kind of information we have today.
Okay. She didn't have a sibling matched donor. Like we were actually planning for a haplo. That's why they were hesitant. Like after the end of induction, we insisted for transplant only. But as I said, like midostaurin could have been tried. Thank you.
Thank you, Dr. Ramesh. From the same note, in spite of giving this, instead of giving 3+7+ midostaurin, can we try a CLAG-based regimen for the same, because that involves tetrabenazine or CLIA-based regimen?
Yes, yes. So
Can we go with that?
Yes, that'll be another proposition to add cladribine. If you incorporate in the induction, that would be another good regimen to go in for. But definitely, what happens with cladribine is in the consolidation arm, either giving more cladribine cycle becomes difficult. So TKIs would have to feature in either post-transplant or maybe if there is a bridge time to transplant, midostaurin would have to be utilized somewhere because you cannot keep giving clap because it will delay the marrow recovery and our subsequent planning as well. So definitely cladribine could form the backbone of induction both for AML and cytoreduction in systemic mastocytosis. But the consolidation strategy should be incorporating a TKI, both the pre-transplant and the post-transplant consolidation.
Sorry, sir. I just forgot to add on. Like we had given dasatinib also during induction. Is that?
So dasatinib wouldn't work when somebody has a KIT 816V mutation. It won't work. It is primarily recommended for a non-KIT mutation or somebody with. So the mutations are clearly defined. There are actually 8 to 10 of them, so you cannot memorize them. But these are not the typical KIT mutation. So if it is a typical KIT mutation, dasatinib would not help. So that is not the way to go about it. Yeah.
Okay. Okay, sir. Thank you.
Thank you, Dr. Ramesh. Dr. Pujita Reddy, your question, please.
Good afternoon, everyone. Thank you, Harun sir, for such an excellent and elaborative talk. I have a few doubts, sir. What is your personal experience with the imatinib for these systemic mastocytosis patients?
So
did you ever use?
Yeah. My personal experience with imatinib and dasatinib, I would tell you. So this patient whom I alluded to in my case, Vignesh, was on interferon, right? So this patient did well for almost 2 years and a half. Now, what I know from the feedback which I've received very recently is with interferon, he had psychosis. He was not tolerating it. He had flu-like symptoms. This is what we see with interferons, right? And then we had nothing to offer to this patient. So we were trying imatinib and dasatinib. So when you see the entire spectrum of mastocytosis, especially the indolent form, 80%, I would say 95% are KIT mutation positive. When you see the aggressive systemic mastocytosis, about 70 to 80% are again KIT mutation positive. So if you ask my personal experience, like I would say I would have treated 3 patients, right? So that's what I would say. And there is not much experience to be shared. But from personal point of view, but if you ask me the evidence available in literature, you would have around 30 odd patients managed with imatinib. The responses were there. And the responses, if you go by the criteria, are all hematological improvements. Clinically, they were meaningful. But if you say how many lives were added into it, if you see there is no long-term data, you would have one odd patient who would have done well on imatinib for maybe a year and a half, not more than that. So I think imatinib is not the way to go about it. The imatinib approval came quite early when we did not have anything to offer. So now that there is midostaurin and definitely there are newer TKIs which are selective, that is, I think, is the way to go about it in systemic mastocytosis.
Sure, sir. And one more thing regarding that DDPCR or ASCO-PCR for monitoring, is there a timeline to check it or?
Yes. So
there the frequency of.
So I didn't discuss the response criteria assessment basically because of paucity of time and there was too much of data being covered. So there is an European collaborative network and there is the American Mastocytosis Society, and they have come to a consensus. Initially, it was all 2016 criteria were all an international group of experts. Now there is a consensus criteria which has come in, which is being proposed. And the WHO is probably revising this. So it has not been approved, but like what you said, it incorporates everything. The clinical parameters, definitely you look at how fast the ascites is resolved, how far the edema resolved. Then there are lab parameters like the cytopenia resolution. And definitely you do marrows to see the VAF burden disappearing. To define the complete molecular responses, you do the MRD assessment as well on flow and IHCs to talk about mast cell percentages in the marrow for MRD, and you do the tryptase as well. So it's all defined. So if you're on a trial basis, it's being done like most of the trials, like the Explorer or the Pathfinder did it on a 3 monthly basis, I would say. But if you see on a day-to-day clinical basis, getting it done, I think we have not been doing the Doppler PCRs even at the baselines. So at least in India, in our practice settings, we'll have to do the baseline testing first, define the mutations, do the NGSs, and do the baseline tryptase, because unless we have baseline data, we cannot even compare. So the thrust, I think, today should be doing the baseline workup completely in the correct way. And then definitely in terms of response assessment, 3 monthly, 6 monthly, yes. So peripheral blood could be a good way to go about doing the BAF burdens in mastocytosis, both for the mutation as well as for tryptase levels. And it needs to be done on a regular basis, yes.
Sure, sir. Sir, and one last one. Are there any special precautions to be taken up for these patients during the allo transplant period?
So when you have actually carefully manage the mast cell activator syndrome, so I would say that is the single most thing. Like even in an amyloid transplant, we are very careful about use of GCSF. So what I want to say, we just don't know what the trigger is for a mast cell activation syndrome. So I would say what makes a difference between life and death for these patients when we do liver site transplant, any perioperative procedure would be to keep epinephrine standby, give antihistamines, give mast cell stabilizers, debulk them to the maximum possible level. That is when a complete response or a CMR should be achieved before you take up the patient for a transplant. With respect to conditioning, there is some evidence, I would say, that a MAC approach would be better than a reduced intensity conditioning in a transplant. A match sibling would do better than haplo transplant. These are the things which I think when you take a patient up for transplant. So debulk maximum, get to the maximum possible CR, CMR, go for a match sibling donor, go for a MAC transplant, manage anaphylaxis better, be prepared to manage anaphylaxis better. We just don't know how many triggers are there. So
Yes,
I would say it's about managing it on ground.
sure, sir. Thank you.
Thank you. Thank you for the question.
Thank you, Dr. Pujita. Dr. Aditi Shah, your question, please.
Thank you, sir. It was a wonderful talk. So my question is in aggressive systemic mastocytosis, cladribine versus midostaurin, which agent do you prefer starting, and what will be the treatment end point? When, like, will midostaurin be continued lifelong, or when do you decide to stop the medications?
So I'll take the last part first. Regarding when we are using midostaurin and cladribine, the treatment is still toxicity, which I told you is either drug-related toxicity, which also includes financial toxicity, and definitely clinical toxicity. When you use midostaurin and cladribine, you don't go into CMRs. You don't go into you generally go into something like remission or hematological improvement. If you see the criteria clearly, the mast cell burden cannot be zero. The MRDs will not be nil. And if you see the MRD itself, the concept is evolving. So generally with midostaurin and cladribine, you tend to achieve maximum symptomatic relief. You debulk as much as possible. You improve the cytopenias, you improve the quality of life, and you continue. There is no end points with any of these agents. So most of the like when I reviewed that literature of 20-year-old data with cladribine, the maximum they could do give in a patient is 16 cycles of cladribine. Most of them would take around 4 to 6 cycles of cladribine. So it was mostly cost and then toxicity, both which limited any further doses of cladribine or midostaurin. Now, problem with cladribine is, I would say you have to give repeated cycles. The patient essentially is hospitalized for some period, there are cytopenias, and you repeat it. So the logistics of cladribine administration, although it is limited to 9 to 12 cycles, which again is just an assumption, right? So the logistics of delivering cladribine is a lot difficult. Midostaurin, with now, I think we have gained some confidence with midostaurin. Most of us have utilized it in the AML setting. So midostaurin is a doable drug. And there is no head-to-head comparison, as again I said. But overall, with the kind of data which has come, midostaurin, I would say now 6, 7 years data with midostaurin. Cladribine, I would say 20-year data. Head-to-head, clinically, you would say in terms of survival benefits, midostaurin would definitely be and having an edge better than cladribine. That's what I would say. And it's doable. It's easy for a patient as well. But financial toxicity, yes, is a major concern with midostaurin, because it has to be indefinite, right? And that will be a problem when you use midostaurin. That otherwise, head to head, there is nothing much to compare.
Thank you, sir.
Thank you, Dr. Aditi. Dr. Aditya Jandial, your question, please.
Hi, Dr. Arun. Fantastic talk as always. proud of you. Okay, so I hope you remember that case of AL amyloidosis that we had anaphylactic reaction of the stem cells during a couple of years ago, and I presented the CPC for that case at PGI, and while reviewing the literature, the one of the reasons for anaphylaxis is occult mastocytosis, and it comes as one of the differential diagnoses in such kind of situations. uh, I think if you look at risk factors for hypersensitivity reactions for IV iron preparations, one of the risk factors is apart from fast infusion rate, other factors is like against mastocytosis. And one of the panelists highlighted association of AML with the increased mast cells in marrow. So my question for you is, if since you have reviewed the literature in detail, so apart from the multi-system presentations for patients with the mastocytosis, where the clinical features are obvious, should workup for mastocytosis be included in patients who have severe hypersensitivity reactions to a lot of immunomodulatory drugs that are available, or monoclonal antibodies, or any drug reaction?
Thank you, Dr. Vidya, for that question and for that compliment. I did cover it up in one slide. So when somebody has a mast cell activator syndrome, be it a near miss or a near anaphylaxis, which has been the patient has been saved, that patient, ideally, if you have to go evidence based, there is this Fuchs score and the REMA score, which I did mention in one of the slides. That these are basically based on the gender and the symptoms which the patient had. And these tell us whether this patient should undergo evaluation for systemic mastocytosis. What I could say practically, yes, every patient who has had a near anaphylactic episode or anaphylaxis episode from which the patient was revived must undergo screening to rule out systemic mastocytosis. Now, the least invasive way to do is to do a serum tryptase level, and definitely we should not do it during the acute phase. Problem is, the acute phase, the serum tryptase level will definitely be very high, although there is a correction factor for that as well. And the second thing is doing a peripheral blood allele specific or a digital droplet PCR for the KIT mutation. Now, the algorithm says the patient who has a mast cell activation syndrome should undergo both these testing in the OPD before the subsequent visit is planned, and they should come with these reports. So in the data which I reviewed and in the consensus from the European group and the American US group, there is a consensus in all such patients they must be uh, evaluated for systemic mastocytosis. But when they did see the pickup rates, when they were utilizing the Fuchs or the REMA, the pickup rates were very high, 60%. But when they were doing it blindly as a part of the study, the pickup rate was 30%. So I would say we must incorporate those two scoring systems into some of our algorithms when we ask for these tests, because these tests are not usually done. I told you, sometimes the tryptase level is difficult to get the test then reported. And what happens is most of the anaphylaxis patients are managed in emergencies and they don't come to our referral. So maybe the physician should be aware of this possibility, and maybe they should be reviewed subsequently. And definitely systemic mastocytosis needs to be evaluated in such patients who have mast cell activation syndrome.
Thank you.
Thank you, Dr. Aditya. Dr. Prakash Chitalkar, your question, please.
Very wonderful talk, Arun. I'm really proud of you because I am a army veteran myself. Thank you so much for the wonderful talk. And my question is, so in the common hematologic consult that we get, a typical chronic liver disease who has persistent cytopenias. So in that setting, how do you? I mean, what are the vignettes which might suggest mast cell activation disease?
So this is one of the commonest referrals we get, somebody with cytopenia, so pancytopenia with a spleen, and 9 out of 10 times it is just CLD with hypersplenism. We don't do marrows, we just take a clinical decision making, like we just say, yeah, it could be mostly, and it generally is, because systemic mastocytosis is a very rare entity. But when we have such a patient of CLD and hypersplenism, before sending the patient back, I would rather say definitely look for any episodes of allergy or near anaphylactic episodes or any allergy which has brought the patient to a medical attention, maybe a peanut allergy or whatever, some drug which that history we need to take for mast cell activation syndrome. Second thing is look beyond the liver, look for any bone pain, any early onset osteoporosis. Look for I would say GI symptoms which are like malabsorption like, and the patient is not gaining weight. Sometimes the problem with CLD is all these are very non-specific, so it's very difficult to sharp it out. So I would say bone symptoms are something which should help us. Lymph nodes are something which should also point to that. If there is some eosinophilia, monocytosis in the peripheral blood, that is another way to go about it. And we would say if the cell counts are not too low, fairly too low, that's when we should think about it. And like what I said, the simplest non-invasive test would be a tryptase and an PCR for the KIT mutation.
Yeah.
But that doesn't rule it out, because if you ask for a marrow, we'll have to tell the pathologist we are looking for mastocytosis, and they will have to do IHCs, because for a blind eye, looking at mast cell aggregates and identifying them and discussing them will be difficult, sir.
It's not easy. Yes. Thank you, Bhargav. Very quick question about the conditioning regime in a stem cell transplant for mast cell disease.
So I just discussed that in a bit, sir, because what has been shown is most of these patients who we prepare for mastocytosis are not transplant fit, and that is when initially there a lot of RIC conditioning was done for these patients, and from the largest body of data of around 70 odd patients who have been followed up for fairly 5 years or so, RIC is not the way to go about it. It has to be a MAC kind of conditioning. Among the conditioning regimens, there is nothing much to choose, because invariably there is some liver dysfunction when you take up the patient. So we generally tend to dose adjust or dose reduce or avoid some agents which are hepatotoxic, but otherwise it's a MAC conditioning which is recommended.
Thank you very much.
Thank you, sir. We have some repeat questions from the audience. We'll just finish it up again, just a repeat call. Question from Dr. Kannan: can serum tryptase be used as a screening test? And
yes. The answer is yes, but don't do it in the acute flare and don't interpret it too much without making correction for the acute, and see the patient as a whole and incorporate the KIT mutations also into your algorithm before you go any further.
Perfect. And another one is, can TKI be used to treat mastocytosis?
Of course, yes. Not all TKIs, it is D6, D8, 1/6-week specific KIT. But what is available to us is midostaurin. Other agents are definitely not available as on date. Imatinib, dasatinib in a very small niche of patients.
Perfect. And another question, last question from Dr. Babita Sodi. If the patient has got KIT mutation in one of the minor criteria, can one major plus one minor criteria be sufficient for diagnosis?
Yes, that's right. That is possible. Yes.
And is mutation still a diagnosis if the mutation is not present and fulfilling one major and one minor criteria? Is it okay?
Yes. So major criteria has to be met, and any of the one minor criteria is good enough to diagnose systemic mastocytosis. All the minor criteria need not be met if a major criteria is met. Yes.
Perfect. So that's all. Any other discussion? Want to ask any other question to Dr. Arun?
Somebody has raised the hand. I think Dr. Y.
Yes, Dr. Tent.
Thank you for the comprehensive talk. May I know your usual steps of diagnosis in differentiating with other CEL or eosinophilic leukemia? I mean, other differentiate diagnosis, how to differentiate?
Okay, yeah. So see, chronic eosinophilic leukemia would be one of the differentials which actually would mimic almost exactly. If you see the symptomatology, it's a multisystemic disease. They can have eosinophilia related, because they ultimately the final pathway is histamine release, and patient symptomatology will be quite similar, like anaphylactic episodes, urticaria. All these could be very similar. So now, and the problem is sometimes mast cell, even systemic mastocytosis could have eosinophilia as a part of the clone or as well. Now, point here is we must not stop at the digital droplet PCRs and show the KIT mutation only. That is wherein when you do the marrow and when you look at the marrow, definitely on a marrow morphologically making diagnosis of CEL becomes very difficult because we see increase in eosinophils and eosinophil precursors in a lot many conditions. Most of the CEL these days are mutation driven, they're molecularly defined and they are NGS defined, right? So you would definitely do a mutation panel or an NGS which would define an additional subset of eosinophilic leukemia in these subsets. So patient invariably may have two of these coexisting, that the CEL and or the eosinophilic clone and the mastocytosis clone may be coexisting in the same patient. That's what I want to say. So to differentiate between the two, you would define them separately.
Yes.
What I was saying is the patient can have both the illnesses and you should use different diagnostic criteria for both. Clinically, it is impossible to differentiate because the symptomatology will be essentially be the same. And patient may have one disease overpowering the other. So in the same patient, you can have eosinophilic leukemia and systemic mastocytosis, but the patient's clinical phenotype may be mastocytosis predominant or driven. It may be the other way around also. It may be CEL, STAT5B driven or whatever mutation, CSF3R mutation driven, but there may be a mast cell clone in the patient marrow, but the patient may not be having symptomatology suggestive of that. So you must look for both. So whenever you diagnose systemic mastocytosis, always look for an associated hematological neoplasm morphologically on IHCs and on the NGS panel.
Yes.
That's how.
So when you order, yes, when you order BDGFR A or B.
Yes. So whenever there is an eosinophilia which is predominant, there are eosinophilia-driven clonal mutations, which could be any of those, like PDGFRA, B, FGFR, PCAM. There are so many eosinophil clonal mutations which could have eosinophilia as a part. So that is what I was saying. It will be part of your NGS, the myeloid mutation panel, which is done as a part of any standard myeloid proliferative neoplasm workup will be part of the workup. It will be part of the workup so that we don't miss out on the clone. And we correctly label the patient as not just advanced or aggressive systemic mastocytosis, but ASM with an associated hematological neoplasm, which could be CEL, like what you said. Yeah.
Yes. Thank you so much.
Thank you. Another question just come up from Dr. Kannan. Should you look for mastocytosis in every case of hypereosinophilic syndrome?
No. So that is not the way to go about. I would say no. Hypereosinophilia, if you see the entire workup, I would rather say first thing is rule out secondary causes, then the primary. And when you do a marrow, probably that is when you would have a suspicion. And I would not say in every case, because the eosinophilia burden is too much for us to evaluate. So I would not definitely do mast cell, or I would say the tryptase or NGS or mutation in every case of hypereosinophilia. Yeah, I would not do.
Thank you. And another question from Dr. Priyanka. How long will you continue TKI?
So TKI as on date, at least with avapritinib, there is a thought process and there is a talk about getting into a complete molecular remission and consolidating with a transplant, or on a trial basis to do a TFR like what you do in CML. So that is a concept which is evolving. So it is just a concept. Otherwise, it's indefinite TKI. Indefinite TKI till I told you financial toxicity or drug related toxicity, or till the patient progresses on that particular TKI.
Thank you, sir. And any other discussions want to ask any other question to Dr. Arun? So yes, so there are no more questions from the audience and no more raising signs. So thank you so much for that lovely and fantastic talk and updating us on this beautiful topic of systemic mastocytosis, and with a wonderful question answer session. Thank you so much for being with us. And I thank all our discussants, as well as I thank all our audience to participate in this webinar, and meet you next Saturday, Sunday with another next best webinars for you. Thank you so much. Goodbye for now.
Thank you. Thank you, Dr. Amit.
Thank you, sir.
Thank you. Thank you, Prakash, sir, for your kind words.
Thanks a